Mic check. Luisa, can you hear me?
Hello.
Nikhil.
Hey, how's it going? Sorry for being so last minute on this. How are you guys?
No worries. We do have a presenter that's not on yet. We're pinging him. Hopefully he's on.
Ah!
It's okay. We have still waiting for a few attendees. I'm not sure. I don't see any attendees yet though. So we'll let them trickle in.
I think it's not open yet
Okay,
for,
that's why.
for them to attend. Cool. I think just a quick logistic thing, I'll just do a quick intro to the whole thing. Just explain like how this kind of came to be, and then we'll just hand it off to you.
Frank, do you need all of us or do you need me on Thursday? Or
So, it's funny, right? Like,
I mean, I'll be on the whole time. I'm happy to be on the entire time and take questions, but you also don't need to see my face if you don't need it. Like you tell me what you need.
yeah, we might I think you can go off, Reza. I think we'll have most of Thursday. Um if I ping you for tomorrow, I might throw a curveball and have you join tomorrow just for moderation. I think that might be good. But we're a little too late for that for this session. So now that being said, if I don't see Ernie join soon, I might have you on Reza for you and I to present this section, which is fine.
I'm here, whatever you need.
All right, can you stay on then?
I'll-
That'd be great.
I'm staying on for the whole hour and a half anyway. So just if whatever you need, I'll just come off of mute.
Okay.
Maybe we should just start letting people in, and then it'll take a couple minutes anyway for people to come in, and then yeah, we can just start. And hopefully Ernie joins in the next few minutes.
All right, sounds good.
I think whoever's admin on your side has to press start.
So it's actually, Frank, you're actually the host because you had started this before me. So I can revoke. Okay, good. It started. Excellent. We're live.
Cool. People are coming to hang. Everyone wants to learn about value-based care. All right, sweet. Let's take bets on the number of live attendees. My God, oh, okay, we already passed whatever my bet was going to be. Wow. This might be an out-of-pocket first. 3. All right, we're at about 400 attendees. That's crazy.
Hey,
Middle
since Ernie hasn't joined yet, I fear he might have been caught up in some type of personal emergency, which I hope is not the case. Do you mind if I call shotgun and you play backup quarterback here?
I'm here.
All right, well, I think we're gonna have to play it. I mean, none of this information is gonna be new. So what I will do is let me go ahead and update
We'll do
slide.
it live. I love
We're gonna
it.
do it. We're gonna do it live, man. All right.
Cool. All right, well, we got about 415 people watching, so this is gonna be good. No pressure.
No pressure at all.
Okay, so let me just give a quick intro, and then in the meantime, we can jump straight into things. So thanks everyone for coming to hang out and learn about value-based care contracting, the sexiest of sexy topics. No, but more seriously, this is a question I get a lot, especially when people talk about value-based care at very high levels a lot of time, like, oh, we need to do more stuff for patients outside of the four walls of the hospital, etc. But there are a lot of practical challenges with doing stuff like that. So I wanted to have a course about how value-based contracts actually work in practice, so you can understand some of the trade-offs when entering a value-based care contract. And so I've worked with the Accorded team in the past on a few of these, and thought they would be the perfect people to come do like a basic explainer of the parts of value-based care contract. So from here, I'm going to give it to Frank and Reza. I think just a quick logistics thing, and Accorded team jump in if I'm wrong here, but you guys can drop questions in the Q&A chat, and we're going to take them at the end. So and in terms of will this be recorded, shared slides? Yes. So for all attendees, we'll be sending this out afterwards. So yeah, with that, I will leave it to Frank and Reza.
All right, thanks all. Welcome to the value-based care contracting course. As keeping with out-of-pocket tradition, we are going to keep this as informative as possible and yet super lighthearted and meme-filled. Nikhil, we're going to try to give you a run for your money here, so look out, coming for your crown. And jump into the topic of value-based care contracting. All right, so course agenda, we're set up for 3 days of action-packed information. Day 1, we're going to talk about getting ready for a value-based care contract. The instructor is Ernie Valenti. We've done a quick switcheroo here because of some personal conflicts. Ernie will not be presenting. We have Reza. Thank you for jumping in at the last minute. And I will be moderating. On day 2, we're going to talk about value-based contract analytics and all that goes into setting up a value-based contract itself and operationalizing it. Day 3, first-hand accounts from value-based care contracts to operations. We'll have Reza, Allison Foster, as well as Kevin Capel with myself moderating. As it relates to logistics, there is a Q&A chat box within the webinar. We will have someone, myself, as well as a team moderating the questions. So as those questions come in, we'll be sure to inject them throughout the presentation in order for the presentation itself to be more dynamic with the audience itself. So we will, I think, be providing a transcript of this call post-webinar. All right, I'm getting the thumbs up from Nikhil, so we can get started.
Let's do it. I'm going to learn stuff too. I'm excited.
All right, sounds good. And Nikhil, do feel free. Please take a look at the question and answer box. We have a team as well. Feel free to interject with questions as we go along. All right. Jumping right into it. We have Ernie, unfortunately not here. However, he did create the content, so I'm going to give him a quick shout out here. Ernie, he's had over 3 decades of experience working with health plans around value-based care strategies, value-based care transformation. Most recently, he led Optum's national specialty value-based care payment strategies, and is now an advisor at Accorded. Reza, would you please do an intro?
Hey everyone, I'm Reza Alavi, internist by training. Spent the last 15 years doing a variety of medical leadership roles. Spent about 6 years at Optum on the medical group side of things, leading institutional affordability. Currently have a small firm called Quintuple A, and we do value-based care consulting, advising, and investing.
Awesome. Also, we have a couple of value-based care practitioners over on the health plan side. Allison Foster, Again, since we don't have Ernie on, we'll have her also as a part of the moderating panel to answer any questions as we go through this material. And I'm going to go ahead and jump. Well, Allison, I know you're going to be presenting and instructing on day 3, but if you can give a quick, intro, that'd be great.
Sure. Hi, everyone. I'm Allison Foster. I am the Director of Value-Based Care at Scan Health Plan, which is a nonprofit Medicare Advantage plan based in Southern California, but serving sort of the western part of the United States. So my colleague Kevin and I will be on Thursday to talk a lot about payer perspectives when contracting with vendors and providers in value-based care arrangements.
Thanks, Allison. All right, we had a slide cutoff issue, but it seems to be okay now. Thanks, everyone. Frank here, I'm the CEO, co-founder of Accorded. My background, I'm a health actuary. I spent 18 years working with health plans, providers, and hospital systems around value-based care contracting, primarily on the contracting, pricing, and administrative side. Really what motivated me to found Accorded was value-based care itself. Seeing all of the potentials of value-based care, yet seeing kind of all of the demands that it places on administrative teams, operational teams, and strategic teams really got me interested in the space, and I'm excited to be talking about those experiences and sharing them with you here today. All right. So I know, Reza, these were Ernie's materials, and we have Ernie joining right now. So I guess now we can all kind of present as a group. Hey, Ernie, thank you for joining us.
Welcome, Ernie. Save me from having to describe what value-based care is. But
all right, Ernie, please take it away.
Sure. So traditional healthcare services were paid kind of the way that mechanics get paid for working on your car. So if they replace your alternator, they get paid for replacing your alternator. If they replace your radiator, they get paid for replacing your radiator. But people are really different from cars, and individual people respond very differently to the same medical treatment. And there are many competing medical treatments that yield similar results for the same condition. So the environment of fixing a human is very different than the environment for fixing a car. And so the method of payment, where we paid, kind of piecework previously, doesn't really match to the a healthcare provider trying to, fix a human being. And value-based payment is a new way of paying for healthcare services that tries to map more closely to the reality of the treatment environment. And it pays instead of for everything that gets in a piecework way. Providers of care get paid on the outcomes that their patients experience. So typically value-based payment, value-based care is going to pay in a way that allows providers more freedom to choose the treatments and methods that they prefer than historical payment methods have done, and also focuses more on the true outcome, the health status, the patient satisfaction, because a lot of times, the way the patient feels about a treatment is really the deciding factor in whether the treatment's the superior one of various options.
Hey, Ernie, not to interrupt you, but do you have another mic or like a different room? Are you kind of chopping in and out of the audio?
Okay, right. The audio is still choppy.
Yeah.
Sorry,
Ernie. Well, yeah, as you're trying to work through the audio, hopefully find another headset. I think what Ernie summarized here is really fee for service versus paying for some alternative way, and really paying for kind of outcomes and value as an alternative to just pure utilization. So when we think about value-based care, I think one aspect of value-based care that has been very contentious is how do we actually define what a value-based care contract is? And so I know hopefully we still have Reza and Allison, but let me know, what do you think in terms of what you consider as a value-based care contract itself? like are pay for performance contracts, upside only contracts considered value-based care? We know that even though, when we talk about plans having value-based care contracts, most of those contracts are not downside or capitation or global risk. It's really pay for performance and or upside.
It's a good question, Frank. I get this question all the time, and not just for providers, but also for vendors who are selling some sort of digital solution. Had this conversation earlier today, right? So people say they're taking risk. So the minimum risk is some level of clawbacks. So you're supposed to have a one-to-one ROI, and if you don't meet it, they're going to have some clawbacks, right? The next level is you're going to take some actual risk, take some downside risk, and you want some upside pay for performance in predetermined levels, let's say, improvements in affordability or ED utilization or inpatient utilization and so on. And then further along, if they're more advanced, they can get into discussions around MLR and so on. I feel like maybe Ernie's back with the mic on. But before that, Allison, what are your thoughts?
Yeah, I mean, I think, any contract where you're incentivizing more than just paying for a service, I would broadly define in a value-based care sense. But I think when you start talking about risk, like you're talking about, Reza, that's really when you're getting into the nuts and bolts of a true partnership with your vendor or your provider, rather than them sort of helping you manage your own risk as a payer or as a risk-bearing entity.
Yeah. And I know there's a question that came in around clawbacks. Usually, Reza, correct me if I'm wrong here, when I've seen clawbacks, they're very minimal. It's like, hey, how much did we pay you for your services? And if you didn't perform up to snuff, we're going to claw back, a small percentage of that, maybe, 25, 50%.
It depends. It depends on the negotiating power you have to get that initial contract. One of my clients is talking to a national payer right now, later on today, and they want up to 100% of their fees at risk, etc. Right? So it just depends on how mature your solution is, how much proof points you have. So conceptually, you have to give up something to get something. And who's got more power, who's got more data, who's got more knowledge when you go to negotiate.
All right. Thanks, Reza. Sorry, Ernie, we can do a tech check as well as continue to see if we got the mic working better.
Yeah, I switched to a wired headset. Hopefully
Awesome.
that's working better.
Okay. That's much better. Thank you.
Okay. And so thank you for stepping in and helping there with that. So there are 6 milestones that we think are at Accorda think are important to be considered when negotiating a value-based care strategy. As a provider of services who might be selling to like a health plan, or when a health plan is interested in engaging a provider of services that prefers to be paid under a value-based arrangement. And we'll cover those 6 milestones. And then as part of that, there are 5, in my experience, common pitfalls that I've seen when organizations are entering into value-based contracting arrangements. And we'll cover those as well and talk about how best to avoid them. So the milestones that are important in negotiating a VBC contract are defining the program, make sure that the program is clearly articulated, how that the theory about how and why it works is clearly well understood, how people are engaged, how measures of progress are taken, and then how outcomes are determined. Optimizing the program impact, as I said before, although you may not have heard me because of audio issues, medical treatments affect different people. The same medical treatment might affect different people very differently. Health issues may be distributed unevenly across the population. There may be geographical areas where people might benefit more.
Ernie,
Yeah.
You're getting into each of the components. Should I just jump into the detailed slides?
Sure.
Okay. We can talk about a program. Use an example.
Yep. So here's a program. This is not a real program, but it's an example that I'll touch on as we walk through the issues, called HeartWalks. And it's for people with cardiac issues who need to exercise in order to improve their cardiac status And it also so happens that people who have cardiac issues tend to suffer from mental health issues concurrently, typically depression. So the program will organize walks for people, nature walks for people with heart disease, because nature walks have been shown, in addition to being good exercise to improve the cardiac condition, they're also improve people's mental health, especially reducing depression. So the benefits of this program for people who participate in it will be improved cardiac health, reduce depression, high patient satisfaction, and reduce cardiac and behavioral health costs for participants. So I'll keep talking about each of these points relative to this phony program, if you will, as we walk through.
Ernie, so we got a question. Well, just a comment saying not all the audience members have a background in health planning and in the health plan space. So just to set this program into context, if I'm thinking about Heart Walks, it's, let's just say, a population health management program looking to support cardiovascular patients, and they're looking to sell or partner with, let's say, a health insurance company, United, Aetna, Cigna, et cetera. Is that correct?
Right. Right, to offer this program, and the reason the health plan would be interested in it is because some of those objectives that we talked about earlier of value-based care, more efficient and effective treatment for a lower cost, high patient satisfaction, all of those things are what health plans try to do for their members. And so HeartWalks would try and sell its services to health plans who are interested in delivering better care to their members.
Got it. Now, I think I will point out that HeartWalks in particular would probably need some type of value-based care arrangement in order to function as a business, because to my knowledge, I don't think guided walks have CPT codes that are reimbursable through the traditional health plan claim setting.
Yeah, that's right. And so this program would probably be sold as a subscription for the number of people who participate in it. And because, again, as Frank said, there's no, this is not an official treatment. It's an adjunct treatment to what physicians and hospitals do. Health plans would be interested in it for the reasons I described, and the people who provided this service to health plan members would be compensated in a value-based contracting kind of arrangement that would occur above and beyond the normal payment of healthcare.
Awesome. All right, so let's get into the details of how to structure this program.
So as mentioning earlier, the first issue is to define the program really clearly to help understand, to help the health plan and the participants understand exactly what the benefits are and who benefits. So clearly this is a program targeting people with cardiac issues. You must focus on people with cardiac issues as those who will benefit from the program. The way they benefit was described a bit earlier: improved cardiac health through exercise and improved mental health through participation in exercise in nature, which has been shown to reduce mental health issues. But again, maybe not all participants benefit the same way. Some things that might need to be considered is, what if people have orthopedic issues or musculoskeletal issues that would prevent them from taking a nature walk, right? Those people would not be good candidates for this program. Or what about people who maybe don't have transportation to get to the meeting point for the starts of the nature walks? Those people might need to be supported in some way by the health plan or by the program in order to participate in it. So all those kinds of issues need to be thought through carefully as you're designing a program and making sure that it really will benefit the way that you think people the way you think it will.
As we jump to the next slide and talk about benefits and coverage, we did have a question in the chat. Just for clarification, when we use the term health plans, we're using it as a broad spectrum coverage for any risk-bearing entity or payer, which includes potential ACOs, those participating in MSSP or REACH that would benefit from this program as well. Since they are on the hook for total cost of care, they can potentially partner with HeartWalks in order to manage their cardiovascular patient population, improve cost of care, and improve their bottom line outcomes.
Okay, great. Thanks, Frank.
Mm-hmm.
Again, part of the definition of the program, I mentioned earlier that some participants in this program may wish to participate and would benefit from the program, but they may not necessarily have a means of traveling to the starting points. for the nature walks. So there may need to be some benefit and coverage tweak to enable people to use ride services to travel to the starting points of the walks, and then those ride services would be paid for either by the program or by the health plan. So those kinds of benefits need to be considered. Will people have everything they need to participate? Will every participant who has the opportunity to benefit from this program have the opportunity to participate? It may require recruitment access to members who are appropriate for the program but won't know about it unless you're able to contact them and tell them. And so you may need to request permission from the ACO, the health plan, the risk-bearing entity, to approach patients who might benefit from the program and describe it to them. And then there must be data exchange typically, or some sort of data capture. We've got a theory about how and why this program works now, but the people running the program would need to take measures of whether mental health is really improving as a result of the intervention. That at the beginning, that's hypothetical. As the program progresses and people participate in it, we're going to need to have data to understand whether the needle is really moving on people's behavioral and mental health as a result of participation in the program. To optimize the program impact, as I was saying a little bit earlier, there may be people who would benefit more deeply from the program, and they may differ from others in noticeable and approachable ways. So there may be pockets of geography where the issues that you're trying to address through the program are more concentrated, and we see heart issues are more concentrated in the Central South here in this map. There may be people who have apparent kind of behavioral health consequences of heart disease, and we may want to screen them using that and take people who have more profound impact of mental health on their driven by their cardiac issues. So again, we want to think about who would really benefit, where are they located, how can we target them and make sure that the people with the most need, who would benefit the most from the program, are reached out to and encouraged to participate. And then making sure that the outcomes of the program are really tuned to derive maximum benefit. So we want to make sure that the people who participate in the program get access to good healthcare quality. There may be some educational component that we add to the program in order to help drive that. Their healthcare equity is very important. We want to make sure that people, again, I mentioned people may not have a means of traveling to the starting point of the nature walk. We want to make sure that those people get supplemental transportation coverage to help manage that, and other kinds of issues that might be barriers or impediments to some groups of people gaining access to the program. We want to make sure that we're saving money by reducing medical, cardiac related, and behavioral health costs, as we hypothesize in the program. And we want to make sure that patients are really satisfied by this. If someone really hates nature, is afraid of bears, there was a bear in the original picture of the program logo, they may not be good candidates for this program. We need to make sure that we're picking wisely the people who participate, making sure that the people who would most benefit have access to what they need in order to participate fully in the program. Our contracting is where is really important, and it's where, again, now we're promising to provide a service to a risk-bearing entity, to an ACO, to a health plan, to someone who's responsible for managing the health of a population of people. But in order to deliver on those promises of lower costs, better cardiac and behavioral health status, we need to make sure that we get access to the resources that we need to make sure that the program can function effectively and can target those people who would most benefit from the program. And the contract is where we do that, where we make commitments to the organization paying us for the program, saying we're going to reduce your cost in this way. And then also we gain access to the resources that we need in order to run the program fully. We would identify how, again, because we're getting paid in an unusual way that is not historically typical, we would need to determine exactly how we would get paid for delivering our program. That would probably, in this case, be tied to something like the number of people who choose to participate, the improvement that we observe in their cardiac status, the improvement that we see in their behavioral health status, and their patient's self-report of satisfaction of participation in the program. We would probably want to scale the amount of money that we got paid, given the philosophy of value-based payment. We would want to scale the payment that we receive to the degree of improvement in those measures of the issues that I just described. Then we would ultimately want to make sure that we're getting enough revenue through the door as the program is running in order to sustain the program, and we may want to build in components into the contract of payment timing and then true up later. To monitor the progress of the program as we are running it, as I mentioned earlier, we've got some thoughts and hypotheses about how the program benefits people, but we want to make sure that those benefits are being delivered long before the program has many months to evolve, right? We want to look at measures of performance that are recoverable, that can be measured as soon as we possibly can measure them. What we want to do is make sure that we've got KPIs, or what are known as key performance indicators, that will tell us about things that we want to measure and observe while the program is running early on, so that if we're not improving cardiac health, if we're not improving behavioral health, we want to know that early on so that we can make any changes that we need to make in order to improve the program. And so we want to develop those measures, test them. We want to define thresholds for saying, oh my gosh, something's going wrong here. This program is not working as we hope it would, so we need to take some action. And if we do develop these key performance indicators or KPIs, and we look at them and we decide, wait a minute, things aren't going the way we hope they would be, we need to make sure that the right people get access to the right information to make the changes necessary to improve the program while it's underway. And so long before the program is running, we need to determine who are the clinical leaders that need to understand if the clinical measures are not improving in the way we hope they would. Who are the financial leaders who need to know if people who should be receiving payment for ride services to the start points are not receiving those payments. We need to make sure that those things are measured and detected and smoothed out if they're going wrong early on in the development of the program. So we need to have a game plan going into it about who needs to get what measures, what information, and who are in a position to take action if there needs to be remediation. And then finally, the payment and reconciliation phase of the program is when finally now the program is underway, we're treating people and we're involving people in the program. Then there are details about when payment is finally made. And the way that health plan claims work typically, or medical payments work, is that they're requested and then there's a long process of getting checked, validated, insured, and then paid. And so there's a bit of lag in the system for understanding kind of what's happening with the program and whether the promised benefits, how the program is delivering on promised benefits, and whether it's meeting the objectives that were specified and committed to in the contract. And so there are some ways that one can take an early look at how those outcomes are developing, given the kind of built-in lag in the payment system that I just described, and make some guesses about whether about where things are going to land ultimately, and then fill in some of the gaps with estimates. And run out and completion is a way to do that. Payment and reconciliation, there are going to be in the contract measures. Those measures are going to be put into a financial formula that calculates, again, we talked about scaling the payment to the degree of improvement observed. And there are going to be some calculations associated with that. And the people running the program need to validate that the payment calculations were performed correctly, that the amounts that they are due are correct, and that the data that they're using to calculate the payments are not suffering from any sort of gaps or anomalies. And then as you determine how the program performed in its first year, you'll learn some things. There may be some disputes that arose out of the payment calculations. Those will have been resolved. Every year, every time that you evaluate a year's worth of functioning of the program provides you with feedback about the functioning of the program and gives you an opportunity to go back to change the things you think will help the program perform more effectively, make those changes, build them into the contracting, and repeat the whole cycle that we just described.
All right. Thanks, Ernie. I'm going to go ahead and invite Reza and Allison back. We have a bevy of questions that came through that I really want to talk about and address openly. So, first and foremost, Ernie, thanks for walking through that heart walk example. We do have an attribution question. What if members who are also seeking care, coaches, providers, etc., and doing other things, how would these programs all claim that they help improve outcomes? How do they even, sort that out?
So let me take that one. I mean, that's a big issue. And as a risk-bearing entity like an ACO or a health plan implements many concurrent programs, there's always a question about which programs are driving the effect that we see. And if a population of people with high costs, like people with cardiac disease, they're going to be the focus of multiple concurrent interventions. And disentangling the independent impacts of those interventions is difficult. It's something that needs to be thought of ahead of time, and that there are ways to calibrate and time the measures in order to help that inference along, that statistical inference along. But doing that was a big part of my job when I was a health economist in health plans, was trying to disentangle the independent effect of multiple concurrent interventions. And some of those arguments are rational, some are statistical, and you need to build in timing and measurement constructs to help you disentangle those questions.
All right.
I would add one other thing, Frank. In terms of a pay for performance gain share, if you have downside risk and upside gain share, that's partly the reason that the risk-bearing entities only provide you a small piece of that gain share, right? They're not going to give you 50% of the delta because there's 20 other vendors that are claiming that benefit. So they might give you 5% or 10% of the savings because it was a multimodal thing, right? So there's other ways that if there's a gray area, you might still be able to get a piece of the value that you collectively created. Just a smaller piece.
Thanks, Reza. Ernie and Allison, either one, would you like to comment on how often a health plan, I guess Allison, probably because you're on a health plan right now, how often would a health plan be willing to do a VBC contract with a new startup prior to any kind of data?
I think when you don't have data, you're really talking about a pilot, and how you want to structure a pilot and how you go into that really does depend on the plan you're working with, the level of risk they're willing to take, whether they see sort of a long-term partnership on the table with you. But I think going into those types of arrangements, you're putting fees at risk, or you're working together on establishing what that data looks like. So it really does depend on, is this a need that they haven't found in the market for vendors out there that do have established data and can kind of prove that there's ROI on their work? And is this a population that is really a high focus for that payer? So is this a disease group that's a high focus for the payer? Is it a market or a region that really doesn't have a lot around there that, something like a virtual solution would be a big value add? But those conversations when you're in that pilot phase and how to expand and how to get out of the pilot phase are really, really important, or you're just going to stay stuck there, or you'll have a pilot and nothing else. So making sure you're going into those conversations with your payer partner on, here's what we're measuring, here's what phase 2 looks like, and here's how we see expansion looking with those sort of stop gates are really important.
Yeah. I'll also add that there have been many kind of academic studies around specific clinical programs not done within a value-based care contract or risk contract arrangement, but have proven to have well-studied efficacies and outcomes. And if you're taking that type of model and you're, putting it into a program or solution within what you're looking to deliver, I think what I've seen are health plans being more willing to kind of go into a value-based care contract when there are those clear kind of studies that have been tested or clinical models that have been tested out in the market, and now you're kind of bringing it into and programmatizing it in a partnership arrangement.
Or sometimes you're approaching an area where performance has not been good by existing programs, right? So people are more willing to kind of rip out what is there by the roots and try something new. Usually a pilot, to Allison's point.
Yeah, I think this also gets to things like another question we have is around medication adherence, whether or not, for cardiovascular management, that's a focus on value-based care contracts. I would say yes, because there's been clear studies to show that those who are, maintaining their statins, for example, or cholesterol medication, show improved outcomes. And so the question now becomes, how do you price and value that medication adherence? And oftentimes those types of more kind of, we know that they're generating good outcomes, but if you can't quantify it directly, it becomes part of more of the pay for performance type of arrangement where I've seen, where it's like, hey, adherence, engagement, A1C level reduction drops, all part of, increased payments for performance, as opposed to true kind of total cost of care or capitation arrangements where the provider's taking on the risk.
Can we talk a little bit about the patient selection part of this? I don't know if that's something we're going to go into later, but there are a few questions around like, how do you select patients? How do you prevent, like, what do health plans think about cherry picking, like particular types of patients to look better? Maybe we can talk a little bit about that.
Yeah, there is a section later on selection and inclusion.
Perfect. We can just go through it there.
Yeah, and I think that's it's listed here as a pitfall, but it really is bigger than a pitfall. I mean, can be a fundamental component of the program. If we could back up a minute, I want to just back up one slide. I just want to refresh people's memory about heart walks. It's nature guided walks, improving cardiac health, reducing depression. Okay, thanks. We can go on to we're going to continue to use heart walks as an illustration to illustrate some of the pitfalls that are involved in developing, in conceptualizing, developing, and implementing a VBC program. One thing that I often saw when I was working in this area and on the health plan side was inaccurate risk adjustment. Most risk adjustment models are statistical in nature, and they're not complete, and they don't adjust out all risk. And so there's some combination of things that need to occur there to make sure that changing risk, I mean, usually what you're doing when you put forward a program that says you're going to reduce costs is you're doing some variation that look at costs before the program started, and then comparing them to costs after the program has been implemented. And so if there are changes between those two time periods in the underlying populations, then that can cause serious problems for your assessment of the goodness of your program. And so risk adjustment is hugely important. It's very complex and statistical in nature, and if it's not, and it needs to be supplemented with other approaches.
Sorry, Ernie. Since you were going in deeper, I was just jumping into the slides because
no, that's fine. Yeah, that's fine. And so in smaller populations that are often the focus of programs like HeartWalks, the variation of risk over time can be even more pronounced and more detrimental to the fair assessment of the program. And so really risk adjustment can level the playing field for both the payer and the provider. As a payer, the person, the ACO or the health plan, you don't want to pay for just good luck, right? I mean, they may just be getting a healthier set of people who participate in the program. And I'll talk more about selection in a moment. But you don't want that, you don't want luck to be dictating whether the program is judged to be a success or not, and whether the payments are made based on that luck. So risk adjustment is a crucially important way to smooth that out. Part of the way to supplement risk adjustment is to make sure that you know what you're doing with high cost and outlier cases. And high cost and outlier cases are, if someone gets in a car accident while they're in heart walks, that is going to drive their costs way up. And you've got to have accommodation for that in the way that you think about the program. Some programs don't address outlier or high cost cases at all. So they just exclude them because there's no part of the theory about why the program works that addresses that population of people. Other programs see high cost and outlier cases as where the opportunities are. And so they're hyper-focused on managing those kinds of cases. So you've really got to have kind of theoretical control about what your program does in order to be able to determine what to do with outlier cases. So sometimes include them, sometimes exclude them, but certainly understand how your program will interact with them and structure the way your program works to accommodate that.
I think that's a really important point that I want to double click on, because, if I'm a health plan, I have 2 points of consideration when managing population health. There's those, healthy need to be managed to prevent them from becoming high risk later on and very expensive. And then there are those that are already really high risk and expensive, and how do I manage them? And if you're a program looking to partner with a health plan, you really need to be clear about what population you're trying to manage and target. And if you do both, then how does your solution or program specifically, clinically, in a very detailed, specific way, address the high cost acute population and how you manage them? And then how do you help, manage the healthier population that are just kind of in maintenance mode and preventing them from becoming high cost? I think that's what, Ernie, you were specifically mentioning as it relates to, like, if you're a program looking to partner with a health plan, like, where are you on that spectrum? Making sure you're very clear about that. And Reza, it looks like you have some.
Yeah, can we take a second, also take a double click on like backward look on high cost versus forward look on high cost, right? So if you have let's say 10,000 lives and you find 100 people who are high cost, like the highest cost of those from a rear view perspective, over the next year, a handful of them, God forbid, will pass away, a handful will regress to the mean, and you only have like a middle category to do an intervention on, and out of those, some percentage will engage, etc., right? But if you have a predictive analytics engine that are predicting who are going to be next year's cost ballooners, and so you have an actual 100 patients that are going to be high cost, and then maybe even more sophisticated, and you have what's the cause of their cost ballooning. All of a sudden you have something completely different in terms of how you can engage and interact and enroll patients into something that moves the needle. So both from a what to do about it, how to talk about it, how to contract for it, this difference between like last year's high cost patients and our best guess of guessing next year's high cost patients is something worth discussing.
That makes sense.
Yep. Let's move on. So again, as Reza was just describing, you've got to understand how your program interacts with high cost patients, and the contract must align with realistic expectations for what you're going to do with that group. So if your program believes there's opportunity there that can be managed, and the program is designed to manage it, those expectations should be made clear in the contract. And if the program is in no way capable of managing people at the high end of the cost and acuity spectrum, then those people, it should be clear in the contract that those people are excluded. And again, that should be considered in conjunction with risk adjustment, because really excluding people with very high cost and risk is a form of risk adjustment. And the obverse of that is including them. So another issue that can cause problems, again, our fundamental methodology here is to look at the way things were before the program started and compare them to the way things are after the program starts. Health plans and ACOs and other payers are constantly negotiating with providers in their network. And typically those providers are negotiating for higher unit costs for things. And so the bar chart here, for example, shows the increase in one CPT code, which is a 30 to 39 minute office visit. It's a very basic, uncomplicated medical service. And as you can see, the cost accelerates pretty substantially over time. And if that dynamic is occurring while your program is operating, it can interfere with inference about whether the program is reducing costs. And so those unit price differences need to be anticipated, measured, and incorporated somehow into the payment method so that their impact is moderated. Otherwise, you're going to end up obscuring inference about whether the program is achieving the desired cost reduction results.
So, Ernie, when it comes to thinking about this unit cost increase, I also categorize this as just medical costs as a part of overall medical cost inflation. Things are getting more expensive, and it's being reflected in how much medical services cost through contracting and other reasons. What is it that you've seen, both from the health plan and or from the vendor side, to kind of really address this when it comes to incorporating this consideration into the contract?
So again, the way that I would historically measure cost increase over time in a health plan would be to look at the two components of cost, which would be this unit price. This single thing is now going up more expensively, actually three ways. Another is that use of the same things are increasing in the same kind of base population of people. So in this example, more office visits are occurring than have historically occurred. So that's another way costs can go up. And then the third way is new treatments come along that are more expensive than historical treatments, and swapping the new costlier ones in for the old less costly ones also causes cost increase. And those latter two are typically what a value-based program can control if healthcare costs are part of a part of reducing healthcare costs are part of the commitment. But the unit price is really in the hands of the health plan. And so keeping track of those three things and understanding again how they interact with the design of the program is crucially important.
Yeah, we have a question come through, is what is an example of incorporating this cost into the payment model? A common payment model is setting the baseline, which is understanding what historical costs are and then projecting them moving forward. So if you can look at this unit cost line, if you can draw a straight line, it's pretty linear, which means that if we were, let's say, projecting into 2025 and you were setting a contract in 2025, you would assume that that line would continue to go up and that medical services would be more expensive according to that line. And so when we're setting benchmark targets as it relates to a contract and saying, hey, here's the bar you need to meet in order to ensure that we're performing, we would want to trend that forward to kind of the year for the contract using historical trends in this case, because as you can see, generally speaking, we're talking about a pretty linear trend.
Yeah, and Frank's really talking about adjusting, follow-up period costs for the increase. And another method that can occur is you can standardize costs in both periods, so that you're really looking now at utilization in a dollar metric, and it completely removes all of these unit price increases. And in reality, I used both approaches in my prior career.
How long is a typical contract period, Ernie?
Contract periods usually run on an annual cycle because, again, a lot of the things we're talking about change. Contracts get renegotiated, provider contracts get renegotiated on an annual cycle, occurs annually. That allows enough time for things to play out where you're really getting a good picture about whether the program is working. Now, the contract may last longer than a 1-year period, but typically measurement would occur at least annually.
Got it.
This is what Nikhil was talking about earlier, which is selection, and it's a concern in both directions. So, Heart Walks is a program that requires people to be in pretty good health, right? Because they're going to travel from their homes to a trailhead and get on a trail and hike in nature, and even relatively low demand hikes require a certain level of physical functioning and cognitive functioning. And so really sick people are not going to end up in Heart Walks. And so that is not adverse selection, but it's beneficial selection. And if we do that, last year to this year follow up in the wrong way, it might look like Heart Walks people do really well on measures of cardiac and mental health. But really what's happening is we're just attracting the healthiest people into our program by dint of the way the program works. And so health plans are not going to want to pay a value-based care program for just finding the healthy people and attracting them into the program. So that needs to be something that's accommodated in the way we think about the payment method for a program like Heart Walks. The other side of the coin would be, there's something about Heart Walks that, people who are already very healthy do the nature walks already. They don't need to sign on to a program that would constrain their choice about where to go and who to go with and what time they start. So you're not going to attract the super healthy people because they're already doing the walks. You're instead going to attract people who have limited social networks or have musculoskeletal or mobility issues and need help. And so that's adverse selection because but the program is, instead of attracting super healthy people, it's attracting the more sickly ones. And again, back to looking at last year versus this year when we operated the program, if you're not accommodating that change and that dynamic in the payment method, it can make things look really bad when in fact all you're doing is attracting relatively sicker people.
All right. So I think Nikhil, you kind of mentioned it in your question and some of the audience questions around selection. I think Ernie very specifically said this is actually quite a common issue when it comes to these types of programs, only because, typically it requires human action to participate in these programs. And when that occurs, that can distort the type of population that is selecting into your program relative to what you thought the population or the patient panel would look like. It could either be healthier, in the case that Ernie mentioned, if they're already kind of doing these walks, if they're already pretty active, they're likely to gravitate towards a program like this. And so you're going to get a healthier selection of patients. It could also work the opposite way. For whatever reason, if the program is set up to select, a more acute or sick population, then you have to understand how that selection works both for and against you, and ensure that proper accommodations are made when it comes to contracting, as well as pricing, as well as reconciliation when it comes to that particular effect.
and again, ways, some common ways that this is addressed is that the way that you define participants in the program would require you to take everyone with a cardiac issue, right? And then look at that population year over year with appropriate risk adjustment and exclusion criteria. And then your program would have to be powerful enough to move the needle for that entire population, even the population of people with cardiac issues who are not good candidates for your program. So obviously, that advantages maybe the payer a little bit more than it does the people running the value-based payment program, but there are other ways to address that as well. The issue is you've just got to understand what the possibilities are, because you may not know until you have a track record whether you've got favorable or adverse selection, and you might need to. That's certainly one of the key performance indicators that you're going to want to build in is, are we attracting the people in this program that we thought we would attract? And if we're not, does the contract have provision for making adjustments for that? And again, in the contract needs to memorialize, this is more or less what I just said. You need to make sure that the contract reflects what you think the population you're going to attract is and what impact that's going to have on selection. And then it's got to have provisions for making changes if those going in assumptions are wrong and not met. And you've got to measure right on top of the performance of the program, whether you're attracting the population you'd planned on attracting is one of the biggest issues and biggest pitfalls in implementing a program like this. And so your KPIs, your key performance indicators, very much have to tell you about who is ending up in your program. And you've got to have some provisions in the contract about what to do if that's different. And then you've also, when you structure a program, you've also got to, again, as I mentioned, if you've got a value-based care program where people have to be at a certain place at a certain time, is your population a good candidate for doing that? I mean, that's something you need to think about. Is it realistic for the people we want to attract to this program and put into this program? Are they the kinds of people who can really do this? Then there may be legal requirements that would prohibit you from implementing a program where some people can participate and others cannot, especially because of health barriers, right? I mean, you may be violating state or federal law if you implement a program that is not accessible to people who are legally entitled to it. So you've got to think that through as you're structuring your program and your contract as well. And then the program specific factors, the ones that I've been talking about, like risk adjustment, inclusion and exclusion criteria, what to do if there's a dispute. All those factors need to be reflected both in the way that you're paid for doing this work and in what the contract says about if things do not go as planned.
All right, if we can have Reza and Allison jump back on, we have a few questions we'd like to go through. All right, we have both Reza and Allison back on. Some questions specifically to kind of the payer decision maker. So, one question we had was, as a vendor, who do you approach in the health plan to even pilot a program? Like, where's the starting point? Who's the decision maker, and what does the negotiation process look like?
Yeah, I can take that. So let's say in the Optum universe, the answer is always, it depends, right? So it depends on if your solution is purely a clinical solution that can drive down total cost of care, you're going to perhaps engage the medical management infrastructure. If it does that, but also really improves quality measures, there's going to be a quality silo of folks. But then it also does that, and it helps with documentation, coding, and things that impact the risk adjustment score for let's say, a Medicare Advantage plan or a delegated risk group. You might be talking to a different buyer. So even within a specific payer? The answer is always it depends. You start kind of floating around the idea of what you're interested in and seeing who can introduce you to the other side, etc.
Yeah, and
Allison, is it different at Scan?
no, I mean, it is correct. I think there's one more bucket, and especially with the program like Ernie's example here for Heart Walks, there's also your product team. So that's a little bit further upstream as far as, choosing populations, but a lot of times for non-clinical programs like Heart Walks, where it's really something that could impact, your lower acuity members or your higher acuity members, you can also approach a product team at a health plan and have it be a product benefit that's accessible to everyone on a certain product or your entire, Medicare Advantage population. So you see those and that kind of the payment model there, it allows you to be a little bit more creative because you're basically being paid for every single member that's eligible, a pretty low amount, and anyone can access it. So think of those like your Headspace that you get or the Calm app that you get through your employer. That's also another option if you have something that isn't super targeted to a certain disease population or requires, a lot of clinical oversight.
Yeah, I think that's an interesting point. I want to mention that like this specific example, we've used a program that's relatively ancillary as it relates to how it directly impacts the clinical care of a patient. I mean, when we talk about value-based care, I guess this is where kind of the confusion and the lies is that it's such a broad spectrum. If you're, a primary care group, they've been taking capitation, especially in California, forever now, and they have been, on the hook for total cost of care. That's really kind of the gatekeeper for a lot of the care through kind of closed networks, referral programs, HMO networks, et cetera. And then you have these other solutions that are coming out to the market that are saying, hey, we have a better kind of clinical solution for this very specific targeted group. Although they don't do direct care delivery or referrals, or they don't, manage the patient in the way that a primary care physician does. And so the payment model is going to be very different. They're all going to be categorized under this, value-based care umbrella, but, we're not, it doesn't make sense for a solution like Heart Walks, for example, to be taking, capitation arrangements or total cost of care contracts, et cetera, given the limited exposure they have and direct influence they have on the patient itself.
Although most programs, and I would add one other character to the motley crew that Reza described, which would be a health economist or an actuary, or any program that has makes a claim about reducing cost through efficiency of care, is going to have a person like that evaluate those claims and yield a decision about whether the theory, the logic behind the program is tenable, and there should be data, right, about if the program's been operating, then there should be historical data, track record data that gets presented as evidence for the program reducing costs as claimed. Or if there isn't, there should be simulated data about whether the program has the prospect to reduce cost as claimed, and someone. So an actuary health economist would be called in typically to evaluate the credibility of those claims based on that information.
We did have a question that come in that says, hey, the annual cycle seems like a pretty short cycle to really determine if there's been any meaningful benefit for something like preventative care. They also quoted Chrissy Farr, a reporter that wrote about this, as well as Sachin Jain, CEO of Scan, that talked about 3-year cycles being a better approach. Allison, since that's your CEO, you want to comment about how measurement versus contract terms and how it impacts, how you've kind of done or seen contracting at Scan?
Yeah, I mean, I think this is a really important issue that Sachin is working sort of across many industry leaders to talk about. I think really it comes down to when you are investing in a population of patients on the upstream, there is the chance that you've spent a ton of time, 2 years in a row, on preventative care and preventative services and wraparound support. for that group that I think Frank, you mentioned earlier, that maybe isn't acute yet, but could be. And so the way that the healthcare system is set up now, those patients, you as a health plan may have invested really heavily on the front end, and then another health plan is actually going to be sort of reaping the benefits of that investment because the patient changed every year, and they have all of these sort of AEP incentives and their sales and all of these different parts of the healthcare system. And so when you're talking about, you know, contracting, you're really talking about who's that population that you have now. And so you may have seen cost of care reduce for your patient population from 18 months ago that isn't the same patient population that you're taking care of now because of that churn that's happening on an annual basis, when, you know, Sachin and other leaders are really advocating for longer time with your same health plan so that you can really have that incentive to invest more heavily upfront, because you will be the benefit, the payer that reaps those rewards.
And I would add
Yeah.
the delegation of risk. It was probably something we're going to talk about in other sessions. Is once some of the Medicare Advantage risk has been delegated to a medical group, the patients are a little bit more sticky, so the turnover is a little less. So then you can start having discussions of slightly a longer cycle, versus if they belong to a pure payer, there's a good amount of turnover every year. So it's hard for them to give you a 3-year contract if they're going to have 10% turnover of their patients every year, right? So like how justified is it that if you want to say we want to have this population, and then 3 years later, the N is going to get smaller and smaller?
I'm going to jump in and say I love Sachin, but I so fundamentally disagree with the idea that we should be locking people into 3-year contracts with plans. It just can also set up a huge set of misaligned incentives too, where it's like, oh, now they're in a 3-year contract, we don't have to like do a ton, right? I think there is something sort of more interesting about like making sure that, I mean, if a plan does really well in a year-to-year cycle, they should just get renewed anyway, right? Because the patients and providers like them.
Yeah. I mean, if there is a runway though, I mean, so people are talking about, I think, needing time for the program to bite, right? So there's implementation time, and then there's recruitment time, and then there's time for the program to work. I think if you're, for the reasons Reza described, if you're not delivering a value kind of after a year, the case gets harder to make, certainly in a health plan. I think while it's true that in maybe a provider organization hangs on to the patients longer, in a health plan, if you're not delivering value at the end of year one, it's not impossible to make a value case, but it gets much, much more difficult. And so I think it can be done. You've got to have really good control over the theory of how your program works. Clinical leaders can be your friends if you're making that kind of sequential argument. If there's a clinical argument that underpins that, they're going to need to weigh in on the rationality of it. But it does get harder. There's no question.
I'm gonna just summarize some of the questions into like one bucket, and maybe we can just chat about those. One is kind of like, what is the interaction between value-based care arrangements and medical loss ratio? So for people who may be new to this stuff, medical loss ratio basically means that payers collect these premium dollars from people. They have to pay out 80%, 85% in medical claims that come in. So, a lot of people, they talk about how this disincentivizes payers maybe from caring about doing more preventive stuff to care about long-term outcomes. So curious, like how value-based care kind of addresses this, but also from like a mechanical standpoint, does this count under MLR? Do you need to use claims so that it does get like, filtered into the MLR medical expense stuff? Just if someone can just talk a little bit about that.
So the MLR is just is like a profitability ratio for primarily Medicare Advantage plans, and it means the medical loss ratio, and it's what percentage of the premium that the health plan collected is being spent in the care of members, the healthcare directly, and not being spent on things like marketing, communications, administration, et cetera. So a higher MLR means that more of the premium dollar is being spent on healthcare services for members. And the range is typically between 75% and 85% that I've seen in successful health plans. And whether a value-based payment program gets included as part of administration or healthcare services depends on accountants, right? It's really, there are accounting guidelines just as there are in other industries, and what gets put in what in the numerator and the denominator is kind of dependent on what the health plan feels comfortable doing, really, and what those accounting guidelines say. And so
in terms of Heart Walks, just bringing it back to Heart Walks itself, there's
Right.
no claims. The program itself doesn't generate any claims. The health plan, the payer is paying for that program. Would that be considered a medical expense in the MLR calculation?
you'd have to make an argument that because it's including healthcare quality and healthcare equity, that yes, that would be the grounds under which you would try and justify putting it into medical expense. If you get audited and that argument doesn't fly, then you would have to take it back out. And again, it's like the accounting standards in other industries. It would be dependent on what the health plan is comfortable doing, and what auditors from CMS primarily would argue, whether they would buy the argument or not.
Sometimes the MLR gets involved in the conversation in the inclusion, right? So they might have a subgroup that has a MLR of 100, 105, right? So these are a subgroup of patients that they're losing money on, and they say, hey, now they might say, these are diabetic patients, or these are our whatever. This category of patients, our actuaries have told us there are MLRs 111. Now we want a program to address them. So sometimes you enter that conversation through knowing that the MLR of a particular population is high, and now you're providing a solution to that. Now your solution might have pay for performance that are not tied to MLR, right? You have other value-based outcomes, etc. But over time, they're going to see that MLR go down, and that's another way of like keeping you in the door.
And remember, the MLR also includes the accuracy of the actuaries who set the premium price, right? So that's a process, and it's in that way it includes kind of an extraneous detail that the year-over-year kind of comparison does not, right? I mean, if the actuaries who set the price were bad at it, that'll affect any sort of MLR being tied to the payment method, whereas other approaches are free of that pollutant, I guess.
Maybe just to change gears real quick and do another group of questions. A few people have asked about kind of value-based care in like a commercial population, so versus Medicare or Medicaid. So again, just quick refresher for people listening. Medicaid for largely low income groups, Medicare for people who are 65 plus, and then commercial, which is usually all people who get their health insurance through their employer or buy it on the exchange, and some people who are in self-insured employer, so where the employer takes on financial risk. Can you talk a little bit about maybe like what are, especially when it comes to these pitfalls, like what are the different pitfalls maybe in each category? Like how do they compare to each other?
Yeah, I mean, I can really quickly just start off, and then I'll let the panel of experts take this on. When we think of Medicare Advantage, that's where we've seen a lot of value-based care contracting on the Medicare side. And the reason being is because CMS and the federal government has set the reimbursement rates through a premium process, in which if you're a Medicare Advantage health plan and insurer that's taking that on, you don't really get to dictate much on how much premium you're getting, which means you have a lot of incentive to start taking that pool of money and start seeding and sharing that risk with providers that are willing to kind of take that on for you. On the commercial side, when we think about employer plans, fully insured group plans, if you somehow misprice, you need more premiums, you just increase the premium the next year, and then you kind of cover your bases, which is why from just where we see most of the action, quote unquote, on value-based care contracting, it's really on the managed care side, so Medicaid as well as Medicare. I'll let the rest of the group take on some of those other considerations as it relates to what they're seeing.
What's the deal with commercial?
Yeah, there's less activity over there. There's interest in some aspects of it. There's interest in quality, there's interest in value-based referrals, they're interested in specialty solutions, but ultimately the inpatient utilization is highest in the senior population. So there's a lot more innovation in the Medicare Advantage space. The other thing I would add is on the quality side of things, right? So Medicaid and Medicare measure some of the same things that go into these HEDIS measures, but Medicaid has different rules in every state. So it's more difficult to have pay for performance based on some of these quality metrics. If you're a 50-state solution, you're going to have different pay for performance kind of measures in different states. If you're in the Medicaid space versus in Medicare, you might decide to have a pay for performance on hemoglobin A1C or blood pressure or statin use. And that's going to be a standardized way that it's done everywhere throughout the country. So there's a little bit more advancement because the Medicare system is more uniform.
I also think that what the healthcare services that elderly people and non-elderly people consume are just very different. And historically, most value-based programs have been focused on managing chronic conditions in a community setting to avoid hospitalization or worse, right? And that's just not as big an issue. There's not the same burden of chronic disease in a non-elderly population that there is in an elderly population. So I think for a long time, that's been an impediment to greater adoption of value-based payment in commercial programs. But with when I was at United last year, I was responsible for implementing programs, specialty physician programs. And so that then becomes a lot different now because it's not about managing this chronic condition to keep people out of the hospital. It's more about making sure that the individual physician performing a relatively more complex service makes judicious treatment choices about what services get used. And so there's a lot more interest in that. And I think that will be the way that value-based payment gets more broadly adopted in a commercial population. Another thing I might say is about now, because we're looking at the pitfalls, in Medicaid, many of these pitfalls can be exacerbated because of the characteristics of Medicaid populations. They tend to be their span of time under which they're insured by Medicaid tends to be variable. People move in and out of work, and as they move in and out of work, they move in and out of Medicaid coverage. People move geographically in Medicaid populations more frequently than they do in commercial and Medicare populations. And so implementing value-based programs in Medicaid can be even more challenging just because of the environmental circumstances of people who are often in Medicaid programs. And so that, I think, needs to be said.
These are great. One thing I've also heard just anecdotally is risk adjustment is just much harder to do in a commercial population. There's like not as many sort of like agreed upon ways to do it versus something like Medicare or Medicare Advantage, which is more.
Yeah, I think the commercial the risk adjustment, statistical risk adjustment method used in Medicare was tuned on an elderly population, and so applying it to a commercial population isn't as good. Now there's after the ACA, there's a commercial version of it. So that's better. A lot of them, the risk adjustment methods for commercial populations tend to be focused on, tend to be proprietary models that are very costly. And then there's also, because non-elderly people have less things wrong with them, there's less signal defined, if you will, that causes some of that to be causes some risk adjustment models to break down.
This is probably something we're going to get to in the last day, but maybe just worth talking about now. There's a lot of questions about things like admin burden in terms of like fee for service versus value-based care. That is one higher than the other. What actually goes into the administrative part of value-based care? Maybe we can just talk at a high level about like, you know, what those two look like and how to think about that as a form of cost also when you're trying to do a value-based care arrangement.
Reza, you're smiling, so I'll let you go first.
I was gonna let you take that.
Okay, I can take it. I think it really does come down to how you design your program. Oftentimes, and a lot of times, if a program, you know, isn't designed well, you're basically doubling your admin burden. So you're still doing all of the things you were doing before. You are still doing, I think someone mentioned prior auth in the questions. Plus, you are spending a lot of time afterwards doing your reconciliation work and sending reports and putting together reports and manually generating files. And so I think, and the biggest thing I'll touch on Thursday is the importance of implementation and talking about implementation prior to signing that contract. So you really do understand what is expected of both sides and who needs to be at the table and what does reporting look like, and you know, do you need claims or can we cap you for things? And so I feel like a lot of the answers today is it depends, and that is the case really with a lot of these programs when you talk about something as broad as value-based care. But you can avoid admin burden if you build a program that, you know, has reporting that's already available and that you really think about implementation really, really strategically. But if not, oftentimes you've got teams that are doing work off of the side of their desk to make sure that you have what you need in your contract, plus all of the other things that happen on the day-to-day with the payer. And it can be the same case on the side of the value-based entity as well.
And if I may add, you know, if you're a full risk medical group, you know, the admin staff are trying to chase down high risk members to provide them extra care to hopefully that we're doing some good for them, right? So keep them healthier and out of the hospital. Now it's hard work, right? There's coordination, there's headaches, there's check the box medicine, right? But there's actually you're chasing after people proactively to provide them better care. On the fee for service side, you're spending a lot of your effort to churn things that are unnecessary just to keep up to make some money. So both have admin, both have headaches, but one, in my, you know, admittedly biased opinion, you're doing the greater good through achieving those headaches.
This was great. One more question that I'll just, again, sort of summarize from a lot of people. How do you decide? I mean, this is sort of a layup for you guys, so I'll let you dump this one in. But how do you decide the price when you go to a payer and you're negotiating this contract? How do you figure out the baseline? What is the role of actuarial services in something like this? This is not a shill. This was an actual question someone asked.
Yeah, I guess I can answer that question since I'm the actuary here. But you know, it's with starting off with actually defining your business model rather than looking at the numbers, right? Like your business model is, what are the clinical groups you're targeting? Are you looking to manage patients, chronic? Are you looking to capture and improve high cost, high acuity patients? Then looking at the data, meaning that really being able to have a firm understanding of what, from a health plan's perspective, they're paying to manage these patient populations, and then looking at that care journey, cost and utilization, taking your clinical model and saying, how is my program going to change that trajectory? And then formulating a cost differential saying, hey, when I change this care trajectory, whether it be 1 year, 2 years, 3 years, this is the savings generated for the health plan. And these are the outcomes I'm looking to achieve clinically. Really, those are two pieces of the story. One, what are your clinical outcomes? And two, what is the financial business case of those clinical outcomes and how can you model it? And that does for better or worse, mostly for worse, because it increased administrative overhead, requires you to kind of really dig into the data and really understand how the health plan Medicon folks, health plan actuaries are looking at their own data to be able to decide whether or not a program is worth investing in.
Just
And I
real
think-
quick, just real quick last question, because I think this has come up from a few people and we're running a little bit out of time. Like, if you wanted to start a process with doing this for a payer, like which department is it that you go to, right? You mentioned Medicon, you mentioned like some of the other departments. Like, who's the best person to sort of target these questions to?
It sort of depends on the
It
program. I
depends.
mean, yeah, I mean, if it's primarily a financial benefit program, then someone in the CFO's line, which would include actuaries and Medicon folks. If it's primarily a medical benefit or a clinical benefit, the CMO, someone in the CMO's line. And then some health plans, but not all, have kind of program. They're constantly on the hunt for programs like this, and they'll consider they're really the best source of entry, because point of entry, because they're used to doing pilots, they'll do them, and they're more willing to gamble on new stuff.
Yep, or the quality team. If you're really focusing on a quality metric, that's the other place to start. But I think it really depends on what your intervention is and what you're trying to improve, and that's your entryway into the plan.
And I would just add to what Frank said earlier about be aware of all sources of value, because some of it may not be financial, right? I mean, patient satisfaction is important to health plans. Keeping members is important to health plans. Keeping their members from commercial as they transition to Medicare, that has value to health plans, and your program may deliver those things in a way that is not directly measured financially.
This was excellent. Good day one, team. We did it.
All right. Just a quick plug for tomorrow. We have a lot of questions that came in that is related to data analytics, how to think about the pipes, setting it up. We'll be sure to cover that tomorrow. So thanks everyone for joining. Nikhil, I'll let you wrap up day one, and then we can.
Yeah, this was great. I think for people who are interested in more contracting mechanics and the specifics of that, tomorrow will be a really good lesson. And yeah, if you guys have any questions, let us know, and we're going to try and get to as many as possible. I think I answered like 30 questions in the chat, but then 100 more came in, so it's a little overwhelming. But yeah, excited to see you all tomorrow. Take care.
All right. Thanks all.